meeting to order. So welcome everyone to meeting number 20 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the second wave of the COVID-19 pandemic. Before we get going, I wish to emphasize that everyone has the right to participate fully in these proceedings in the official language of their choice. If at any time there is an interruption or problem with the translation services, I urge affected members to advise the chair or the clerk without delay. We will do our best to correct the situation. So I'd like to welcome this time our witnesses. We have, as an individual, we have Dr. Gary Kobinger, professor at University of Laval. We have, with the National Research Council of Canada, we have Mr. Mitch Davies, president. With the University of Alberta and Entos Pharmaceuticals, we have Dr. John Lewis, professor. And with that, I would invite the witnesses to make a 6-minute statement. We'll start with Dr. Kobinger. Dr. Kobinger, please go ahead. 6 minutes, please.
I had to be the first to start with the unmute button.
Yeah.
Good morning, everyone. I was not expected to start with the 6-minute statement. I will then start by telling you I'm a professor at University of Laval. Before that, I was in Winnipeg as the chief of the special pathogen program in the National Microbiology Lab that I edited for 8 years. My expertise is on vaccine development. Being from NML, I led the group that developed the VSV vaccine for the year after Heinz Feldman left. The vaccine that has now been licensed by the FDA and EMA in Europe. I believe I'm here to talk about vaccine and manufacturing. I'm actually not too sure. I'm so sorry. I did agree to this with the little information, but I'm pleased to be with you and be very happy to answer your question. And since I'm probably still within my 6 minutes, I will say that we have been facing many challenges, which I've seen personally on the international level. I'm also, in full disclosure, a member of the advisory group called STAG-IH, that is the main advisory group that advised the WHO at the executive director level in emergency operation. And at that level, I've seen challenges from many regions of the world, starting with Southeast Asia, when the virus emerged December 31st, the first report, and then going through the world with all the different challenges that were faced and are still being faced by at the world level. In Canada, I was part of the vaccine task force, which I stepped out of voluntarily due to concern from transparency. I think been widely a public decision at the end. Most recently, following a discussion with a journalist, had a public few statement that indicated my position that I strongly believe in the Canadian capacity, as much on the intellectual capacity than the manufacturing capacity. Well, when it's not that everything is available, but everything can be built, and we have the knowledge here in Canada to develop those vaccines and to bring them all the way to a completed phase 3 and licensure, and ultimately in good time with improved manufacturing in Canada as well. Part of my expertise also sits in the development of therapeutics, mainly based on monoclonal antibody, which touch a bit the same technology as AbCellera is doing, which you may have heard as well, as they have received an important funding from the Canadian government, federal government. I think that will be it. I'll be happy to talk about any of those subjects at the more regional level or national level or international level. Thank you so much.
Thank you, Doctor. We'll go now to the National Research Council of Canada. Mr. Mitch Davies, President. Please go ahead, Mr. Davies. 6 minutes.
Well, thank you, Mr. Chair, for the invitation to speak to you today about the National Research Council's role as part of the Government of Canada's response to the COVID-19 pandemic. I'd like to begin by acknowledging that NRC facilities are on the traditional unceded territories of many First Nations, Inuit, and Métis people. Their ancestral footsteps and rights extend beyond the boundaries that exist today, and we respectfully honor these people's rights, history, and relationships with this land. On the specific topic that's the subject of the committee's current study, I would like to address the NRC's role in the government's efforts to develop vaccines and therapeutics for Canadians and to increase our country's domestic biomanufacturing capacity in the near and medium term. The NRC is working with partners across government to advance research and development for vaccines and therapies to prevent and treat the spread of COVID-19, in line with the best advice provided by the Government of Canada's Vaccine and Therapeutics Task Forces. This includes the NRC's collaboration with BBI Vaccines, first announced in March 2020 to develop a vaccine targeting COVID-19 and related respiratory viruses. The NRC is also supporting Vido Intervac at the University of Saskatchewan on the development and production of its COVID-19 vaccine candidate. Canada's support for Vido Intervac was among the first decisions made to support Made in Canada vaccine projects. Through the National Research Council's Industrial Research Assistance Program, we're working closely with Made in Canada vaccine and therapeutics developers and providing more than $32 million to advance 6 of the most promising domestic vaccine candidates and 4 domestic therapeutics candidates to prevent and treat COVID-19. In support of the government's effort to expand Canada's biomanufacturing capacity, the NRC is preparing to manufacture COVID-19 vaccines through the construction of a new Good Manufacturing Practices Compliant Biologics Manufacturing Center at our Royalmount site in Montreal. Once completed, the new Biologics Manufacturing Center will be capable of large quantity, end-to-end production of vaccines, approximately 2 million doses per month, depending on the vaccine candidate. I'm pleased to report construction of the new facility is on track for completion by the end of July 2021. The completion of technology transfer for a specific vaccine and Health Canada approvals of both the facility and the vaccine and related manufacturing processes will then be the steps remaining to achieve production for use in Canada. To this end, on February 2nd, the Prime Minister announced the signing of an MOU with Novavax to pursue the production of its COVID-19 vaccine at the NRC's Biologics Manufacturing Center. This is a significant milestone in this project to be working with a vaccine producer with a product well advanced in the development process. Finally, in support of Canada's biologics manufacturing capacity for research, the NRC is also building a permanent clinical trial facility at our Royalmount site in Montreal. Once complete, this facility will be able to produce 500 liters of clinical trial materials per month to support future vaccine research and development in Canada. Further to the work underway to assist in bringing vaccines and therapeutics to Canadians, I'd like to share specifics about the broader NRC contribution to deliver many other measures as part of the science, innovation, and industry response to COVID-19, supported by close to $800 million in new funding. Significant among these measures was doubling funding available to Canada's innovative companies through NRC's Industrial Research Assistance Program. This increased funding supported jobs and preserved value through the business and operational challenges caused by the COVID-19 economic downturn. In addition, the NRC leveraged its experience to build a Made in Canada system to test lots of new-to-market critical PPE, representing over 120 million products that were made available to the Canadian marketplace to meet the needs of frontline health workers. We provided over 3,000 COVID-related advisory services to innovative firms, created close to 900 youth job placements and postgraduate employment opportunities, and supported over 2,200 firms and more than 26,000 jobs through the Innovation Assistance Program. In closing, I want to assure Canadians that the NRC has pursued many avenues to secure solutions to the many challenges brought on by COVID-19. We leveraged our long-standing relationships from labs to factory floors. I want to recognize the work of NRC employees across the entire organization who have worked tirelessly to deliver so many critical initiatives to support Canadians during this challenging time. I thank you for the opportunity to speak with you today, and I would be pleased to take your questions.
Thank you. We'll go now to, from the University of Alberta, Entos Pharmaceuticals, we have Dr. John Lewis, Professor. Please go ahead, Doctor. 6 minutes, please.
Great, thank you, Chair. And good morning, ladies and gentlemen, and I appreciate the opportunity to share our perspective today. My name is John Lewis. I'm the founder and CEO of a Canadian company called Entos Pharmaceuticals. It's located in Edmonton, Alberta. I'm also a professor at the Faculty of Medicine and Dentistry at the University of Alberta. I've worked for many years as an academic scientist and also an entrepreneur, developing novel diagnostics for treatments for cancer, age-related diseases, and now COVID-19. Entos Pharmaceuticals is an innovative Alberta-based biotechnology company with a track record in the development of state-of-the-art treatments for a wide range of diseases using a platform we call Fusagenics. It's a genetic medicines platform. And Entos, in the context of the current pandemic, has developed a single-dose, fridge-stable, pan-coronavirus vaccine against COVID-19 that is about to start human clinical trials. The Fusagenics platform that underpins our COVID vaccine candidates was developed as a result of years of Canadian academic research, and our COVID-19 vaccine is manufactured in Canada for the benefit of Canadians and hopefully potentially the world. So here we are, rapidly approaching 1 year since the coronavirus outbreak was declared a pandemic. It's really taken an incredible toll domestically and worldwide in terms of mortality and death, as well as had a staggering economic impact. Having access to a safe and effective vaccine really remains our best hope of returning to normal. And I'm happy to say that the biopharma industry has really risen to the occasion. Companies from around the world have worked faster than ever thought possible on the development, evaluation, manufacturing, and deployment of COVID-19 vaccines. And remarkably, today, there are 2 highly effective vaccines rolling out globally with emergency use authorization in Canada and several more under consideration. So, and I'll repeat, this is astonishing speed. And I think the reason for this astonishing speed is really twofold. So first, we've seen key innovations recently in genetic medicines. It's not by luck that the first 2 approved vaccines are both genetic-based vaccines. And genetic vaccines use RNA or DNA to safely teach our immune system to recognize and effectively defend against novel coronavirus that causes COVID-19. So these new generation vaccines are much faster to develop, test, and manufacture compared to traditional vaccines. Are also more effective. So we've also learned that traditional vaccine development and manufacturing has moved at a significantly slower pace, and vaccines developed using traditional technologies haven't performed as well as the genetic-based vaccine against COVID-19, although obviously there's a lot of research and clinical trials yet to complete. So importantly, and I'll come back to this, genetic vaccines can quickly adapt to a changing virus and its new, more dangerous variants. So I think the second reason that effective vaccines are available within a year was a rapid, decisive, and significant upfront investment in vaccine development and manufacturing made by countries such as the US and the UK. So this approach of investing substantially in multiple vaccine platforms and efforts really recognizes the risk of pharmaceutical development, that only some efforts will be successful. Most importantly, it allowed these companies to move quickly and boldly without financial risk. And this is a key difference between these efforts and Canada's domestic vaccine response, and one that I'm going to be talking about because it directly impacted Entos. So this brings me to the people's mind. Why is Canada lagged behind other countries such as the United States, and how do we get back on track? So from our vantage point, from my vantage point as a small but dedicated pharma company, working literally 24 hours a day, 7 days a week on a COVID-19 vaccine since last March, the answer is pretty obvious. So Canada was pretty slow to make the initial decisions for domestic vaccine development and manufacturing. Despite having internationally recognized expertise in vaccine development and manufacturing in Canada's innovative companies, we have Nobel Prize winners in infectious disease. We have vaccine pharmaceutical manufacturing capacity. We took a careful, risk-averse, and committee-based decision approach that led to a relatively modest amount of scattered funding for companies in Canada to develop domestic vaccine. And this put the financial risk of vaccine development and our country's national security on them, which I think was a mistake. So when the pandemic hit, we at Entos recognized that our fusogenics DNA technology could address key limitations in genetic RNA vaccines, namely the limitations in storage and stability and rapidly scalable manufacturing. So we completely pivoted our research and development operations from developing gene therapies for cancers and rare childhood diseases to developing COVID-19 vaccines. And using our own internal funds and a considerable financial risk, we developed a couple of lead COVID-19 vaccine candidates that on the science side induce strong neutralizing antibody response and durable cell-based T-cell response against the COVID-19 virus in animal models. So we've invested heavily over the past year in clinical, good manufacturing, established a clinical production pipeline, and performed all the clinical, regulatory, and toxicology assessments that we needed. So unfortunately, this pandemic is not ending anytime soon. Vaccine and manufacturing and deployment is going slower than expected, and not just in Canada. I think Canada missed the opportunity to get on top of the first wave, but there's still time to act and catch the second wave. I think with bold leadership and a swift commitment to fund the vaccine manufacturing industry and bring it up to world-leading standards right now, we can still make a difference to Canadians in this pandemic, and we can prepare for the next pandemic. I think the time to do this is now. It's not too late for Canada to invest in the development and manufacturing of Canadian-based genetic vaccine technologies. So I have 3 recommendations I'd like to put before the committee. Provide substantially increased funding for private Canadian biotechnology companies to remove the financial risk to rapidly develop and manufacture made-in-Canada COVID-19 vaccines. Financially support the expansion of genetic vaccine manufacturing capacity across Canada. And thirdly, to support an innovative procurement agreement for Canadian pharmaceutical companies that will make these innovations available to Canadians. So I hope these recommendations will provide an opportunity for the Canadian biopharma industry to raise more capital and take their successful Canadian products through the clinical trials, positioning Canada as a world leader in biological and genetic-based medicines. Thank you so much for your attention, and I'm happy to answer questions over the hour.
Thank you, Doctor. We will start our round of questions. We'll start with Ms. Maguire, I believe. Ms. Maguire, please go ahead, 6 minutes.
Thank you, Mr. Chair, and thank you to the witnesses. Mr. Kobinger, I just wanted to ask you, you quit the vaccine task force for lack of transparency. Do you ever raise these concerns with anyone in Mr. Baines' office or anyone within the government? And if you did, what'd they say?
I did have many discussion with Roger, who was acting as the secretariat or coordinator of that committee. That was mainly over the phone. I did communicate my concern also in several emails. Just to go back to my concern, what they were is the task force was formed in June of 2020, but was not known publicly until weeks had passed. After that, the member of the committee did not want to be made public. After that, their conflict of interest, this is from internal discussion. Their conflict of interest, they refused to make them public. This was going against every committee advisory group I've been on, and I did communicate those concerns to Mr. Roger, and that's it. And it didn't.
We've got a lot of. Thank you. We've got a lot of people. There's a lot of billions being lost in Canada. A lot of people still losing their lives. We're way behind almost any comparable country, and every day, we keep losing dollars but more particularly the lives of individuals. The Liberals kept touting robust vaccine portfolio, but to date there hasn't been a large number of needles being put in arms. We're getting another 400,000 or 500,000 today for this week, which gives us about 1.6 to 2 million vaccines in the next month. The Americans are doing 1.6 million arms a day per day, and I'm just wondering if you can talk to that part about the portfolio is big, but there's nothing being developed.
Yes,
arms.
I will add that actually I did appreciate everything that Dr. Lewis said. I think he's spot on. And there's what you can see with just a few minutes in this discussion is there's a disconnect between, for example, what was stated by NRC that everything is done and the best 6 vaccines are advancing, and the disconnect is with the reality that vaccines are not being made available to Canadians. Just to add to this, we also have listen. We are the first and only team as of now that have brought the vaccine from the lab all the way to licensure. Of course, Merck did help. Of course, Merck did a lot of projects, but this vaccine was born here in Canada. We have the experience how to do this. We have prepared for this. We had a vaccine, Zika, in 6 months in the clinic using a DNA platform. This was published. This was public. Before that, we did others. And we got to COVID. We had a vaccine against COVID, which is the same platform that we knew worked against SARS-1 in the early 2000 when I was at NML. It was ready in mid-February of 2020, and we couldn't find funding. So I think and by my fault also, because I did participate in the task force, that was excluding me from the only real funding track that could have brought this vaccine to the clinic. I did it knowing that it will hamper my team and it will be an handicap. But I was really hoping that above all this, we would find a solution.
So it's never been developed by Health Canada.
It has never been funded at all. I mean, we did receive $1 million to do the preclinical study. The only track we had then to go get money was CIHR. We did apply first. They said not enough preliminary data. We got back with all the preliminary data. By the way, our vaccine has the same potency than one of the commercial mRNA vaccine, which I don't want to name. Same potency in preclinical data in animal model. We went back to CIHR and we were told that two things. We were told we were too late because the mRNA vaccine are working and no other vaccine are needed. And second thing, that we didn't have experience in phase 3 clinical trials, which, by the way, nobody has in Canada but Medicago. So if that was the requirement, then nobody should be funded now. Here we are. Thank you.
Thanks for your time. Mr. Lewis, do you ever get a chance to stress the importance of getting the funding out the door to Canadian pharmaceutical companies with anyone in either the minister's office or the prime minister's office?
Yeah, thanks for your question, Larry. Absolutely. Obviously, we've been relatively busy developing a vaccine and getting our manufacturing up to speed, but absolutely, we exhausted pretty much every connection that we had to try to reach members of the government, including a letter directly to the prime minister's office.
Yeah, and if that funding was made available to Canadian pharmaceutical companies right at the very beginning of the pandemic, how much further ahead would we be in getting the Health Canada approvals now?
Yeah, I'd love to put that in perspective. So, estimate between 350 to 600 million to bring a vaccine all the way from discovery to the end of phase 3 and licensure. A small smattering of this funding was offered to companies throughout Canada. Through NRC, for instance, a maximum of $5 million to get to the end of phase 1. So this really put the major part of the burden of development on the companies themselves.
Last Friday,
I think to finish your question, yeah. So I think if we'd received upfront funding at the beginning, and Gary sounds like he has a fantastic solution as well, we'd be well into phase 3 toward licensure by now.
Thanks. Last Friday, the committee passed a motion to review the various vaccine contracts that the Liberals have signed. We've got a lot of, there's been a huge lack of transparency in those right to this date, and that's why we're pleased that the committee passed it. But as someone developing a vaccine, and just as a Canadian yourself, what should we as parliamentarians be looking for in those contracts to determine if the government's vaccine strategy was a success or a failure?
Yeah, I can't answer. I'm not a vaccine procurement specialist, but I would say, it's more of a question of logistics. Expecting other countries to develop and manufacture vaccines and not prioritize their own population over other countries, I think was a little bit misguided.
Thank you, Ms. McGuire. We go now to Mr. Kellaway. Mr. Kellaway, 6 minutes, please.
Thank you, Mr. Chair, and thank you to the witnesses for being here today. Folks, access to vaccines is top of mind for all Canadians. I believe in our strategy when it comes to domestic vaccines and therapies and our decision-making process and the supports that have been put in place to help Canadian companies working to find solutions to COVID-19. Our government's objectives from the early days of the pandemic were actually threefold. Secure access to the leading international vaccine candidates, invest in the most promising Canadian vaccine and therapies, and make strategic investments to rebuild Canada's domestic biomanufacturing capacity. So given our strategy, and this is for Mr. Davies, Mr. Mitch Davies, my questions will be directed to you. Our government, Mr. Davies, invested over $23 million through the NRC Industrial Research Assistance Program to support Canadian companies responding to COVID-19. And the NRC indicated that it was using this funding to provide advisory services and research and development funding to 6 companies for their COVID-19 vaccine candidates. So 3 questions, Mr. Davies, and please feel free to do a deep dive on the 3 of them. Can you comment on the development status of any of these vaccine candidates, number one? Number two, can you describe Canada's past and present pharmaceutical and bioproduction landscape? And three, in your opinion, what does Canada need to do to rebuild or build up its pharmaceutical sector and bioproduction capacity to manage future variants and pathogens? Thank you.
Thank you, Mr. Chair, for the questions. And I'll start with the question of the long-term biomanufacturing capacity in Canada. And it's a matter of great importance. And in fact, the government recognized in the fall economic statement that a full plan and full engagement with Canadians, which is now underway under the leadership of Innovation, Science, and Economic Development, to build that capability out in terms of productive capacity is necessary. And in fact, it's actually necessary because we have all of the intellectual leadership, the scientific leadership, the capability in terms of research and breakthroughs, which is demonstrated by the candidates that we're supporting through NRC IRAP and other vaccine projects that are underway in Canada, that we can deliver the end-to-end solution to Canadians. And certainly it's something that this COVID-19 pandemic has illustrated for us as the need to catch up and make significant investments, which of course the government has indicated it's prepared to follow through on, and is doing so for the example of the Biologics Manufacturing Center that the NRC is currently constructing, which will be a long-term facility that'll be available for pandemic use and be a reserved capacity for the country. I would say the vaccine candidates that we're working with through the NRC IRAP, we're in close contact with each of them, following their clinical progress, following their pursuit of their study. And again, we'll be prepared to follow up and work with them on an ongoing basis to support their needs going forward as they have success in their development programs. And obviously this will establish a strong group of made in Canada candidates with Canadian IP with the ability to pursue those projects for Canadians. Thank you for the question.
Thank you so much. Mr. Chair, I can yield the floor. I had 3 questions and I appreciate the answers to those questions.
Thank you, Mr. Kellaway. We go then to Monsieur Thériault. Monsieur Thériault, allez-y, 6 minutes, s'il vous plaît.
Merci.
Thank you very much, Mr. Chairman. And thank you to our witnesses for enlightening us today. Now, given the current crisis, it's important not to repeat the same mistakes of the past, and we cannot sit on our achievements. In fact, we have to point to our past mistakes so that we learn from them and never end up in a situation which, based on what you're saying, Drs. Kominger and Lewis, saying that today we could be in a very different situation if sufficient research, investment had been made in research. $23 million. Is that enough to fight a pandemic like the one we're in? As far as I'm concerned, just asking the question is answering it. Dr. Lewis, you were talking about substantial investments. In fact, what amounts were you referring to? If Canada really wants to be able to fight a pandemic in future and to work with everything Canada has to offer in that sector?
Yeah, so thank you very much for your question. So yeah, no, absolutely. I mean, I think hindsight is 20/20, but I think it's extremely clear that if you look at the success around the globe, decisive and upfront funding of multiple vaccine candidates all the way through to the end was key to both their success and their speed. Because the key, we talked a lot about be able to speed up clinical development. Previously, the average time for a vaccine to get from discovery to approval is over 10 years. And without compromising safety, we've been able to dramatically compress that time by spending money, what's called at risk, on multiple stages in parallel. And I think this was absolutely required to get to the goal much quicker. And I think in the future, not only can we, I think we're missing commercial manufacturing capacity in Canada. We have the great seeds of that, and obviously investments have been made to improve that. I think we can make much more substantial investments, and this will then put the burden in the future really on the discovery and clinical development, which I think requires upfront investment on multiple shots on goal to ensure one of those goals gets in.
Dr. Kobinger, on February 16th last, the government of Quebec declared that it intended to finance up to $2 million. A vaccine which your group has been working on, has developed. It's quite surprising that you first receive $1 million and that with that money you were able to get some interesting results, but that you didn't get any extra investment to pursue your work, to do the clinical trials. What does that attitude on the part of the federal government say to you? Thank you. I appreciate the fact that you said that we could have done better in certain areas and we could do better in the future. But from the outset, there's been a disconnect between the projects which have been subsidized and the fact that they haven't been able to progress. If you look at what's happened in the States and Great Britain, really huge amounts were invested there, but here $1 million, well, that's not going to get you very far. However, in Canada right now, we don't have a structure or a follow-up once the initial subsidies have been paid out. So projects might be going well at the start, might need more support as the projects advance and as they face obstacles. So they need follow-up investment. And yet here in Canada, there's a wait-and-see attitude where the government might want to invest somewhere else. So I think that ultimately not enough money was invested, and that's why Great Britain decided to massively fund the 3 most promising vaccine candidates. And they gave $300 million per project, or they were willing to invest that much money. And now they have a vaccine which has been certified in 50 countries. So in our country, we've got a different approach. Money is sprinkled here and there, but there's no follow-up. And in my case, we tried to develop a vaccine within a nonprofit. And so we were able to cut 80% of costs. The vaccine would belong to all Canadians, but we couldn't continue with it. There was no follow-up, and there was no way we could compete with other countries. I was on the committee which helped to choose the projects. I only have a few seconds left, and I think I'll come back during the second round of questions because I have more complex questions. But what I take from your answer is that there was no overall proactive strategy on the part of federal government to bring together all the players to leverage the bioproduction capacity in this country. And the government said from the very outset, didn't say, Canada has to be independent. We were laggards, but I'll come back later on. Thank you, Mr. Thériault.
MP Davies, please go ahead. 6 minutes.
Well, thank you, Mr. Chair. I'm going to direct my first questions to Mr. Davies. Mr. Davies, last Thursday, the co-chair of the Federal Vaccine Task Force, Mark Levanin, told the Industry Committee that domestically producing and supplying a COVID-19 vaccine was never possible in Canada before the end of 2021. However, from March to August of 2020, both Prime Minister Trudeau and Minister Navdeep Bains repeatedly set the expectation that Canada would be producing 250,000 doses per month by November 2020 at the NRC's Royal Mount facility, and up to 2 million doses by the end of the year, by the end of 2020. In fact, the Prime Minister sent out a press release on August 31 committing to that. My question to you is this, simple. In 2020, did or did not the NRC have the capacity to produce vaccines in Canada?
Thank you, Mr. Chair, for the question. The Health and Human Therapeutics Research Center in Rosemount has a pilot plant facility and has had that facility for many years. We can produce a vaccine product, but it requires a good manufacturing practices approval, Health Canada approval for the facility. And in the case of a specific vaccine candidate, would have required an emergency authorization for the production of that candidate for human use. So in the case of the commitments and the statements made, the pilot production level of production, which is the 200,000 doses, was certainly the goal of the NRC to put in place the necessary procedures, processes, and changes in our facility in order to accomplish that. Of course, we were targeting an international vaccine candidate. It's well known. It did not come into the facility, so therefore, without the product, you can't produce. But the facility is capable of a level of production that is in line with what's been said. But of course, by the time we reached the fall, we were dealing with a scenario where we had approved vaccines coming online. We had, of course, them starting to be distributed in December in Canada from approved vaccines that had, of course, advanced very rapidly internationally that Canada, of course, had acquired.
Sorry, Mr. Davies, I have limited time. I don't need a long explanation of what happened. I asked you a very straightforward question. So I'm taking from your answer that we did have the capacity in 2020.
Mr. Chair, the question of capacity and the question of authorization and being able to produce it for human use, those are two different questions.
Okay.
And so I just want to be very clear for Canadians that I'm not indicating that we had Health Canada approval. We did not have an emergency product approval in train at the time of the fall of 2020. And we were working in collaboration with other vaccine candidates in the country, but again, not producing for human use. We're working with Bido Intervac, for example, or BBI vaccines.
Mr. Davies, what would your explanation to Canadians be then for why the Prime Minister of Canada said on August 31st that we would be producing 250,000 doses of vaccine in November, which at the time he said it was, about 60 days later?
Mr. Chair, the explanation is that, of course, the plan at the National Research Council was to position that facility for emergency use. And that's exactly what was occurring right through the fall period of 2020.
Okay.
And as far as Health Canada approvals, as far as the circumstances of what products would come into the facility, there would be no way to know precisely at the end of August exactly how it would turn out over the course of the fall. So I would say that would explain the question of what ultimately took place at the NRC facility.
So perhaps the Prime Minister should have been a little less unequivocal, I would think, on August 31st, based on your testimony. Mr. Davies, Minister Anand also told the Industry Committee and this committee that she asked all 7 vaccine manufacturers if they would produce vaccine in Canada. Were you part of any of those discussions?
So at the time that discussions were taking place, Mr. Chair, for vaccine acquisitions, I was not in the role of president of the National Research Council, although I can say that in the circumstances that the minister described, there was certainly discussion of whether the NRC could produce a technology transfer could take place to the NRC, for example, with the AstraZeneca candidate. Of course, also with Novavax, which now, of course, has borne fruit into an MOU that we've now signed with Novavax. So those were definitely ongoing conversations.
You've anticipated where I'm going, Mr. Davies. So AstraZeneca, Minister Anand also said that AstraZeneca turned Canada down because Canada did not have the capacity to produce. Was that because the NRC facility had already been committed to the CanSino project? Is that why the AstraZeneca was identified a lack of capacity?
Mr. Chair, I think the direct answer is the one that the minister provided herself, which was for a company such as AstraZeneca to undertake a vaccine technology transfer to the NRC to a pilot facility was not considered to be a viable or a project of interest for AstraZeneca because, of course, they were producing at large scale in other locations around the world. For example, working with the Serum Institute, which produces 1 billion vaccines every year. So I think it's more of a question of whether it made
capacity.
sense for them commercially, although we technically can obviously handle that kind of vaccine at the NRC's facility. It's a question of whether that was going to be an opportunity that that company would offer to Canada.
Okay, I wanted to ask you about cell culture. In 2019, I understand the NRC had at least 500 liters of cell culture. That's more than twice as much as the UK had. And they, of course, have developed domestic vaccine production. Does the NRC still have that 500 liters of cell culture? And if so, is it being used?
Mr. Chair, as I indicated in my previous answer, the facility has a pilot capability, but again, it's not approved for human use. So that facility, for example, has been used to produce vaccines for animal use before that have been commercialized. We obviously can use the facility to support production models and to help advance vaccine development, but whether or not Health Canada would allow that facility to be approved is a question for Health Canada to have to come to a conclusion on the facility itself, whether we meet all the standards.
I asked about cell culture. I asked about the liters of cell culture.
Thank you, Mr. Davies. So committee, that brings round one to a close. It looks like we would have time for a quick round two. So I'm going to propose round two with 4-minute slots for the main parties and 2-minute slots for the NDP and the Bloc. So with that understanding, we will go ahead now. We will go back to, I believe it is Ms. Rempel-Garner, I think.
Thank you, Chair.
Sure.
Dr. Kobinger, did you, when you were on the vaccine task force, recommend that Canada pursue the CanSino agreement?
Absolutely not. I actually voiced very strong concern, despite the fact that, to my surprise, this was officially the first recommendation of the committee, but I don't know. We have never really discussed it, so I don't know how it made it as the first recommendation.
That's interesting. I'd like to see the minutes of the meeting. Do you think the minutes should be made public?
It's not up to me. I don't know. You would have to ask to, but I think it would be normal, yeah.
Oh, well, the person who would be in charge of that is here today, Mitch Davies. Since the NRC is in charge of the vaccine task force, can you please table all minutes of the vaccine task force with committee by the end of this week?
So, Mr. Chair, thank you for the question. I believe the vaccine task force is coming before this committee later in the week, and the Secretariat. And I think it would be a question you would best address to them, because as president of NRC, I don't have no role or involvement directly in supporting the task force. It's operated at arm's length from me, with the secretary, and of course supporting the task force members, who are all volunteers. So they work.
What role do you have with the vaccine task force then?
From Mr. Chair, from the perspective of the president of the NRC, obviously our role is to provide administrative support for the committee, but it operates, of course, in accordance with its co-chairs and its members and how they proceed.
With regard to administrative support, would you take minutes of the meetings?
Mr. Chair, the secretary to the vaccine task force would take minutes of the meetings and record all the deliberations, the outcomes, the advice letters to ministers, all the indications of conflict of interest, declaration of interest, all the sort of administrative support. Yes.
Mr. Davies, will you commit to tabling the minutes of the vaccine task force with this committee by the end of this week?
Mr. Chair, I'm not in a position to make that commitment. Obviously, I think that would be a question that's best addressed to the vaccine task force in terms of what they'd be prepared to share. And of course, given that they have a lot of confidential information that's been provided to them by vaccine makers, that's an important matter that they have to take under their own discretion.
Dr. Kobinger, you can imagine my frustration in this situation. Do you think that it's reasonable that the head of the NRC would perhaps provide parliamentarians with minutes of the committee that was making decisions on the vaccine for COVID?
Well, I will answer this way. I advise the community to actually not only be very transparent when everything that touches the vaccine, which is the vaccine task force, but even to include a person from the media to record the meetings from the beginning. This did not happen, of course. I was not necessarily expecting it, although it was done.
But you did advise the government to release the minutes of the vaccine task force or have a journalist. Did the government tell you why they wouldn't do that?
No.
Do you think that perhaps Mr. Davies is in a position to provide these minutes to the committee?
I'm sorry, I don't know exactly the structure past the chair and co-chair. Unfortunately, I don't know exactly how it works.
Dr. Kobinger, why do you think it is, or how about this? Do you think there's anything else that needs to be made public that came out of your time at the Vaccine Task Force that parliamentarians on this committee should be reviewing?
Listen, I think that initially the first priority was to try to have access to vaccine from Big Pharma, which was done. The Canadian federal government did very good there with finally signing 7 contracts. The second priority was to build up from day one, not to wait, to build up capacity in Canada, which means from the beginning, the development of vaccine and the manufacturing, knowing very well that the PPE had been an issue and that will face another issue.
Thank you.
Thank you, Ms. Rempel-Garner. We'll go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead for a minute.
My questions are to Mr. Davies, at least to begin with. I'm interested in your existing capacity to manufacture vaccines. Now, the other Mr. Davies has stated that I gather the Prime Minister or you have said that we had the capacity to make 200,000 doses per month, and it could be ramped up by the end of 2020, the last year, to 2 million doses per month. You also, in your reply to Mr. Davies, seem to suggest that you could make an AstraZeneca kind of vaccine. I would assume similarly you could do the same thing for Johnson & Johnson, because again, it's an adenovirus-based vaccine, but you've said that AstraZeneca didn't seem interested in either contracting with you if you were to have either a voluntary license to produce one of these adenovirus-based vaccines, or contract with one of those companies, or if you were to receive compulsory licensing via the government. Could your facility start producing vaccines, and how fast could you start, and how many could you make?
Mr. Chair, thank you for the question. I just want to clarify the 2 million doses per month that's been referenced by the honorable member and in the previous question relates to the Biologics Manufacturing Center, which is now underway. Construction is going well. Will be completed by the end of July. And then we will begin a technology transfer process to position us to have engineering runs and production by the end of this calendar year. And that is the facility that we're working with Novavax under MOU to pursue production at that facility. And again, I think the distinction here is that at that scale of production, with the capability of our scientists at the Human Health Therapeutics Research Center, Novavax was willing to embark because that was going to serve their commercial purposes and obviously support making Canadian vaccine and their product in this country. The question of the pilot plant is very different, and I think that's where there's a limitation in terms of what any large global manufacturer would do at that level of production with Canada. And I think that opportunity has not presented itself, and I think there's a good reason to understand why not. But again, we're pleased that the large-scale Biologics Manufacturing Center has had some progress with the recent MOU.
So if you were to have had a contract with someone like AstraZeneca with the pilot plant, how many doses could you make per month at the pilot plant?
But Mr. Chair, the goal in the pilot plant would have been able to produce for emergency use under emergency use authorization, something in the range of 100 to 200,000 per month, if that had been able to be pursued. And obviously that wasn't the position that we were in last November. So obviously we'll have that capacity and capability on an ongoing basis, but I can't obviously reverse how the course of events occurred over the summer and into the fall. And again, there's certainly some very clear reasons as to why that was not necessarily the kind of opportunity that was going to attract one of the larger global scale vaccine producers.
Now, we've been much criticized for the fact that we don't have the capacity, we don't have anyone here in Canada manufacturing one of the vaccines. In your opinion, is there any company, is there any facility in Canada that if they had the secret formula, they had the cooperation with one of the manufacturers who's come out with a vaccine that's been successful through the phase 3 trials, if we were to give them that secret formula through voluntary licensing, contracting, compulsory licensing, is there any facility in Canada which would have the capacity to start producing vaccines faster than we can get them in from other countries through contracting like we're doing now?
I'm sorry, Doctor, your time is up, and we're really short of time.
You had the yellow card up, and I wouldn't mind an answer to it.
A very quick answer. I was using my cards on the 5-minute slot, but we're on 4-minute slots. I apologize. A quick answer, if you please.
Thank you, Mr. Chair. I think I would refer to the vaccine task force and the position it took in terms of what was the fastest path to have large-scale doses to Canada, and it was to acquire them. And those are the doses now coming into Canada. They've been coming in since December, and of course, we'll be ramping up. And obviously, it can't come fast enough. There's not a Canadian that wouldn't want those doses faster. But that was the strategy they recommended that the government adopt, and that's the government pursued that strategy through the APAs that it signed.
Thank you. We go now back to Mr. D'Entremont. 4 minutes, s'il vous plaît.
Thank you very much, Mr. Chair. I was just sort of quickly wondering with Dr. Lewis, Mr. Davis, when it comes to the construction, I mean, you're saying it's going to be ready or the construction's ready by July of 2021. When did construction begin, and when could conceivably the Royal Mount facility be constructing or getting vaccines out the door?
Mr. Chair, thank you for the question. The construction at the Royal Mount site started last summer, and I assure you that it has been proceeding at a very rapid pace under circumstances that are very unique. We're building a building under COVID-19 health protocols, have to take due regard for the workers, the health and safety, and I think they've made astonishing progress to date. And again, we're very hopeful to be on track to have construction complete by the end of July. There will be 250 odd pieces of unique equipment purchased and have to be installed in that building, and it's quite a massive undertaking in terms of scope. And again, I thank the honourable member for the question.
So Pfizer was able to upgrade their facility in just a few months. I know you're saying they're going at a fast pace, but quite honestly, why can Pfizer do it so quickly and NRC/Canada cannot?
Well, Mr. Chair, in our case, our facility started with a green field of grass. Okay. And I think that explains, obviously, the scale and scope of what we're undertaking, and the fact that it now is a completely enclosed building with HVAC systems, walls, equipment being procured and stored in facilities ready to be installed, I think actually is quite a solid accomplishment in the circumstances. But again, we don't take any of this for granted. It's a very complex undertaking, and biomanufacturing is a very exacting business. And ultimately, we're going to need Health Canada's approval and certification of that facility, and then certification subsequently of the production process of any given vaccine candidate. And we don't take any of those things for granted. And there's no pass with Health Canada. The bar doesn't change.
But quickly on that issue, so if your construction is done in July, how quickly do you expect? I'm sure you have a ballpark of how long it would take for Health Canada to approve that.
So, of course, Mr. Chair, I can't speak for Health Canada, and be very careful not to do anything to suggest that I do. Obviously, we'll be working towards having engineering runs at the facility by the end of the year that then would be available for evaluation. And obviously, this facility will be very important as we work towards the scenarios that we obviously face with COVID-19, potentially having to provide annual vaccination, deal with the variants that are emerging, and obviously provide long-term biomanufacturing capability for Canada that's available in circumstances that we faced over the last year.
Okay. My next question is to Dr. Lewis, and I'll run out of time quickly. So you talk about more resources, and you have three particular recommendations on how to do this better. Is NRC involved in the work that you might want to see happen? Do they play a part in that, or is there a bigger player that we need to engage in this?
Yeah, no, thank you for your question. Yeah, absolutely. So we've been engaged, as has been mentioned with the timeline. The Vaccine Task Force did select 6 companies to be supported by NRC IRAP. Entos Pharmaceuticals was one of those companies. We've been working closely with some fantastic people at NRC to help us with our clinical program, bringing our vaccines to phase 1 clinical trials, and we've received commitments of support up to $5 million to do that. So I think we've obviously all the people working on this task are extremely dedicated, and we're very have gratitude for that support. I would say, but again, and we're going to get there. We're going to get through phase 1. We're going to we're talking with NRC now about funding the phase 2 part of it. But I think in the interest of speed, this needed to happen at the outset from the very beginning to fund the full process from beginning to end, so we could take that risk and move quicker.
Roger that.
Thank you, Mr. Dantoul. Nous allons maintenant à Monsieur Thériault. Monsieur Thériault, allez-y, 2 minutes.
Please go ahead, Mr. Thériault, 2 minutes. I'm sorry I didn't hear you, Mr. Chairman, but I think it is my turn. Now, Dr. Kolbinger, you said, and I quote, Canada's approach is we're going to let others develop vaccines, we'll buy them cheap, and our approach of at-home production is still in development. So Canada is a G7 country, and it decided to take COVAX vaccines itself. But the pandemic showed that Canada has seriously underinvested in basic research in the last dozens of years under various governments, and that's what got us to where we are today. Tell us more about the effect of this underinvesting in basic research, which has affected domestic production against COVID vaccines, and how that reflects on Canada's actual capacity in the sector. Thank you for the question. Well, we did make some investments, NRC, $56 million in the CanSino project, which went nowhere. We also made other investments, but one of the major challenges is not so much in the investment itself, it's how the investment money gets to the right places and whether there is a follow-up or not. The NRC is going to build a production facility. Well, this model exists nowhere else, that a federal department waits for approval from another federal department to produce vaccines. In very few cases, this might have unintended consequences, because we need to be able to compensate people, in fact, who have side effects from some vaccines. This federal model, I certainly hope it works, but it doesn't exist elsewhere. At this point here, it seems that we're putting all of our eggs in the same basket. Thank you, Mr. Thériault.
To Mr. Fisher, I jumped right over him. We'll go back to Mr. Fisher now for 4 minutes, please.
Thank you very much, Mr. Chair. It's always great to hear Mr. Thériault. I want to thank the witnesses for being here. Dr. Lewis, I want to thank you as well for all the work that you've done on cancer research. I've read up a little bit about you, and it's quite astounding what you've accomplished, so thank you for that. Mr. Davies, not the MP Davies, but the other Mr. Davies. I wonder, so I know there have been significant investments in domestic vaccine production, whether we talk about the National Research Center's $170 million, the Novavax project at University of Saskatchewan in partnership, Precision, Medicago, Abcelera, Entos, all the different groups that we've invested in. Maybe you can expand on that, but also talk about the importance of those investments and what they might yield down the road.
Thank you, Mr. Chair, for the question. I can highlight, 3 of those investments because they're each very interesting in terms of capability that's possible for Canada in the future. For example, Medicago, working on a unique virus-like platform based in plants. Obviously, it's been supported to build out its productive capacity, which when it comes online, and obviously presuming that's successful process to approve the vaccine, would provide very considerable amount of biomanufacturing capability in the future for Canada based on a novel vaccine platform technology that Medicago has been developing for many years. PNI was mentioned as well, again, a leader in terms of the lipid nanoparticles, the new type of mRNA vaccines, and an area where there's a significant Canadian leadership, in fact, longstanding leadership of companies in Canada in this space, which is new and obviously has been the news of the COVID-19 in terms of technological development, as these new types of vaccines are very important in terms of responsiveness, and that capability will be there in the future for Canada. BBI Vaccines is working on a platform that they're intending to address a broader spectrum as well of coronaviruses, including SARS and MERS. Again, another very important Canadian technology developed in Ottawa at the research center that will be able to be advanced for the future. So these do obviously give a sense of the capability in Canada, and of course the funding that's been provided will allow those capabilities to be advanced considerably in this time.
Thank you for that. And you know, a lot of people will say, well, why do we need this in the future? Why do we need this? You know, first of all, we want to return to a time where we have domestic capacity to develop and manufacture vaccines for future viruses, but also for COVID in the future. So maybe just touch on in my remaining time a little bit about the value of, and an understanding that it's not just you know, we're going to have Canadians vaccinated by September, so we won't need anything else. You know, talk a little bit about the you know, the potential future of a future need for Canadians for vaccines, and the ability to manufacture them domestically being of utmost importance.
Mr. Chair, I'm not sure if that question is directed to me, but I would say that, you know, the biologics market and global outlook is very strong. I think the RNA DNA medicine area, which has been mentioned by Dr. Lewis, is obviously an area of high potential, not only for treating viruses of the kind like COVID-19, but all range of diseases. I think this platform is very powerful for the future. And obviously these investments now and supporting Canadian companies to realize their objectives will set us up well across a whole broad spectrum of products that the world will need and Canadians will need. So it's actually quite encouraging that we have such strong capabilities in our country, and obviously we're pleased to support those companies.
Thank you, Mr. Chair.
Thank you, Mr. Davies, or Mr. Fisher. We go now to Mr. Davies. Mr. Davies, please go ahead, 2 minutes.
Thank you, Dr. Kobinger. Drawing on the advice of the Vaccine Task Force last September, the federal government pre-ordered 72 million doses of the vaccine candidate developed jointly by GlaxoSmithKline and Sanofi, and that represents Canada's second largest vaccine supply agreement. Of course, that vaccine development has suffered from significant delays after failing to produce a strong immune response in trials. Dr. Joanne Langley, one of the task force's co-chairs, holds a $700,000 research chair at Dalhousie, partly funded by GlaxoSmithKline, and she's worked with Sanofi on research and as a consultant. But according to the task force's website, there were, quote, no direct material linkages, no conflict of interest, and no need for her to recuse herself from discussing the company's product. At the same time, in February, we received evidence that the Federal Vaccine Task Force determined that co-chair Mark Levanen, who was the CEO of Sanofi Canada for 17 years until 2016, who still owns shares in Sanofi, who is consulting with drug companies and who remains the director of 2 other drug companies, also had no direct material conflict of interest in assessing the Sanofi vaccine. My question is it possible to say with certainty that conflicted members did not provide biased advice with respect to vaccine procurement in these circumstances?
This is just a matter of opinion. Thank you for the question, but I will answer that there is evidence of conflict of interest, at least perceived from my perspective, including that one member sold for $20 million of equipment while being on the task force to the federal government for doing fill and finish. So I think these are unfortunately, I think, informations that were not reviewed, in my view, by an independent ethic committee to assess conflict of interest.
Should they be reviewed?
Absolutely, it should have been reviewed before starting the work with this task force. Like for every other, I do conflict of interest statement monthly for WHO, and they are due before we open the line. And if they are not done, we cannot participate. Thank you.
Now, I know the WHO has a video link allowing anybody to tune in the US as well, webcast its meetings on YouTube. Should Canada do the same?
Absolutely.
Sorry,
yes.
Mr. Davies, that'll be your last question. Thank you.
Thanks. If the witness could just answer, please.
Yes, the answer is yes. We should. And there was media also present on the meeting at WHO, which could also be done here. Thank you.
Thank you all. We're a little over time on this panel, but I thank all the witnesses for your time today and your very helpful testimony. And with that, we will suspend and bring in the next panel. Now resumed. Welcome back to meeting number 20 of the House of Commons Standing Committee on Health, where we are meeting to study the emergency situation facing Canadians in light of the second wave of the COVID-19 pandemic. On my panel today, as an individual, we have Dr. Kashif Prasada, emergency physician and assistant clinical professor at McMaster University. For the Canadian Institute for Advanced Research, we have Dr. Alan Bernstein, President and Chief Executive Officer. And with the Department of Health, we have Dr. Supriya Sharma, Chief Medical Officer. We will start with statements from our witnesses. We will start with Dr. Prasada. 6 minutes, please.
Thank you, Mr. Chair and members of the committee for taking the time to listen to our comments today. I am pleased to present on behalf of the Critical Drugs Coalition, a grassroots group of frontline physicians, pharmacists, and academics. We do not seek nor receive any kind of funding from any entity, public or private. We want to provide recommendations for how the federal government can further the goals of mass vaccination and improve the overall security of Canadian drug and vaccine supplies. I myself am an emergency physician in Toronto and have treated critically ill COVID-19 patients, including many who have succumbed to the illness.
Pardon me, doctor. Pardon me, your sound is very broken up. I'm wondering if it's adequate for the interpreters. I wonder if the interpreters could let us know if that's working at all.
No, it is not possible. It's cutting too much. I'm sorry.
Too much? Doctor, I wonder if you could maybe plug in your, unplug and plug in your headset again and see if that improves the sound.
Is this better?
Say a couple more words.
Okay, testing.
That's good.
Okay. Yes, that's good. Thank you very much. Please resume. I will start the clock. Resume the clock. Thank you.
Okay, apologies for the technical issues. So I'm an emergency physician in Toronto. I've seen many people unfortunately pass away from COVID. I was also a key member of Conquer COVID-19, a community group that helped source PPE at the start of the crisis, and Masks for Canada, which successfully advocated for mask wearing bylaws across the country. And my attitude and that of many of my colleagues is that, we've got a mess here, but let's see what we can do to fix it and save lives. That's how we approach our patients, and that's how we should approach this crisis. Drug and vaccine shortages are not a new issue. They've only been made worse now in this pandemic. and it's been an ongoing health security issue for over a decade now in Canada. In August 2020, we sent an open letter to the Prime Minister's office detailing our concerns and highlighting some realistic and cost-effective solutions to include domestic manufacturing. The letter is co-signed by the Canadian Medical Association, the Ontario Medical Association, and many other national bodies. Our current vaccine shortage shares a common root with drug shortages, the lack of dependable and scalable domestic manufacturing. We have the following 3 recommendations. Number 1, Canada needs local production of drugs and vaccines. mRNA is a new technology that has incredible potency in fighting COVID-19, cancers, and possibly other viruses. When I was a lab student 20 years ago, this stuff was science fiction, and the advances made are just incredible. With virus variants, we all need periodic boosters, possibly for years, like we do with the flu. And we have the expertise from the testimony we heard earlier from companies like Aquitas and Providence Therapeutics that can make it here. There's also the promise of second-generation genetic vaccines that can induce longer immunity, and these companies are working on it, on the ones that we spoke to. It's great that federal funding is flowing to these companies now, but this support needs to continue. This is a nascent industry, and the technology underlying it is going to revolutionize pharmaceuticals, cancer care, agriculture, and it's crucial that we get on board now. It's great that it's also in the provinces that are losing other traditional industries, and that these are thousands of high-quality jobs, so it's a win-win for the country. Our second point is that science coordination and communication needs to improve in this country. We are losing a head-to-head comparison with the UK, US, Israel, and many other countries. The UK was able to mobilize a unified effort across industry, academia, and government, and had a cabinet-level post of vaccine minister. I'll give you an example just from my personal history. I, along with half of my U of T class in 2003, was quarantined during SARS after inadvertent exposures. Many of us survivors from that time have been trying to get attention on issues like PPE, drugs, and vaccines, but there's no one to talk to, no network to access, and no way to warn the government what we knew was coming back in 2020. We need to involve grassroots frontline providers, scientists, industry leaders in this in a regular network of advisory groups like the UK does. Get the meetings online, make them public, get the deliberations public, and that's how you share information freely. Our third point is we have some grave concerns from the front lines on the vaccine scale-up and rollout. The rollout so far to healthcare workers has been fairly chaotic. Many rural providers have not gotten their doses. If the government can't get this right with a smaller population like that, what are the chances it's going to work for 37 million Canadians? We should keep things simple as the UK has done. Avoid overly complex criteria and tell the public about plans. Be transparent. Who is getting it? When and where? Focus on the most important thing at all, which is get vaccines into people's arms as quickly as possible. Another point we've discovered is that community providers have not been engaged in the vaccine rollout so far. Family physicians and pharmacists can deliver millions of doses a week, but they're not involved. They have access to and good insight into vulnerable patients and communities, unlike others. And another frontline insight is that some have been able to squeeze out extra half doses out of the Moderna vials and combine them into a single dose, but they're being discarded right now because there's no approval for unorthodox procedures like that. But in a crisis like this, we should look at any option. Our final point on the vaccine rollout is that we should seriously consider giving a single dose of the vaccine to as many Canadians as possible. Just today, we have seen 7 schools in BC closed because of outbreaks, and likely airborne spread of the South African variant, which is widespread in the city of Toronto now, in Mississauga. Variants are spreading quickly. My own hospital logged 12 last week, 5 more today, and they're more contagious and likely airborne. We should take pride that we've vaccinated many long-term care patients. We are discounting the long-term consequences of even mild COVID-19 infections on younger populations. We should not assume that if they only get mild or moderate illness that they're fine. 15% of them will get what's called long COVID syndrome. They'll have memory issues, chronic pain, chronic fatigue, and this will last possibly for years. They won't be able to go to school or work in their jobs. Normally healthy, able-bodied people will have their quality of life ruined and forced onto long-term disability at extreme cost to themselves and their families, and this may even affect children. Imagine if 15% of our children couldn't taste anything or had chronic pain and were unable to go to school. In summary, as frontline workers battling this pandemic, we recommend that we build vaccine and drug capacity in Canada. We improve communication with frontline workers to decision makers, and finally, we ensure that we have an effective vaccine rollout and protect as many Canadians as quickly as possible with a first dose of the vaccine. Thank you very much.
Thank you, Doctor. We go now to the Canadian Institute for Advanced Research. Dr. Alan Bernstein, President and Chief Executive Officer. Please go ahead, Dr. Bernstein, 6 minutes.
Thank you, Mr. Chair, and thank you to all members of the committee for your time and interest on clearly what's a very important matter. My name is Alan Bernstein. I am President and CEO of CFAR. We are a Canadian-based global research organization, but I believe I've been called as a witness here today because I also serve with honor as a volunteer member of the Canadian Federal Vaccine Task Force. As you know, the Vaccine Task Force was formed in June of last year to advise the government on the very best strategy to secure a safe and effective COVID-19 vaccine for Canadians as quickly as possible. In doing so, we were also tasked to look at both domestic and international candidates and to look at the state of biomanufacturing capacity in the country. The Vaccine Task Force is made up of a distinguished group of immunologists, vaccinologists, vaccine developers, biomanufacturers, ethicists, and lawyers. We serve as volunteers, providing our very best possible advice in a timely and manner in a very changing and uncertain environment. Where, as you will recall, there was no vaccine last summer, nor was there any clear whether there would ever be a vaccine. And I want to stress that. Most vaccine journeys actually end in failure. And so we were really trying to cover our bases with the vaccines that we recommended to government. Our very first meeting was on June the 16th. We've now met at least 40 times as a task force for a total of over 125 hours, plus roughly an equal amount of time devoted to studying the proposals that were put in front of us. Let me stress one thing. Our primary objective and the charge we were given by ministers was to recommend those vaccine candidates that were most likely to lead to safe and effective vaccines for Canadians as soon as possible. At our very first meeting, we quickly decided not to put all our eggs in one basket, to put many shots on goal. You have to take, if you want to win the game. So we also decided that given the uncertainties and the seriousness of the situation, we would hedge our bets by recommending at least 2 vaccine candidates for each one of the 3 main scientific platforms that are available: RNA vaccines, a new platform, viral vectors, and protein subunits. Such a diverse portfolio of candidates might also reflect the needs of different target groups in any immunization strategy that government might decide to implement. We were also very cognizant of 2 factors. First, the majority of vaccine development journeys end in failure. And second, the successful development of a vaccine through trials to regulatory approval to scaled up capacity to rollout is best characterized as a voyage in very rough seas. We therefore felt that Canada needed an appropriately diverse mix of science platforms and firms within the portfolio of candidates that we would ultimately recommend to ministers, even if that meant recommending that Canada purchase more vaccine doses than we might need for our own purchase. Although ministers made clear that the first priority was to recommend the very best vaccine candidates, some special attention should be paid to domestic proposals. 24 Canadian proposals were carefully examined, and 3 were recommended: Medicago, Variation Biotechnologies, or VBI, and Precision Nanosystems. These 3 companies are receiving, I think, significant government support for vaccine development through the Strategic Innovation Fund. The other domestic candidates, some other ones, showed promise, but for a variety of reasons, the Vaccine Task Force felt that they were at too early a stage for significant investment at the time we looked at them. We recommended that 6 of these projects be referred, therefore, to the National Research Council for funding through IRAP, the Industrial Research Assistance Program. The 6 projects that received funding in that way were Biodextrous, Entos, Glycovac, SimVivo, Providence Therapeutics, and IMV. In addition, several companies such as Entos and Providence received significant additional funding through grants from the Canadian Institutes of Health Research and the Next Gen Fund, respectively. Thank you. Thank you, Mr. Chair.
Thank you, Doctor. We go now to Department of Health, Dr. Supriya Sharma, Chief Medical Advisor. Please go ahead, 6 minutes.
Good afternoon, Mr. Chair. Thank you for the opportunity to appear before the committee today. I appreciate this opportunity to highlight how Health Canada has been using agile regulatory processes to expedite the access to COVID-19 vaccines while maintaining high standards for safety, efficacy, and quality. My name is Dr. Supriya Sharma, and I'm the Chief Medical Advisor at Health Canada and also the Senior Medical Advisor at Health Canada's Health Products and Food Branch. I want to begin by saying that since the beginning of the pandemic, our fundamental priority has been to ensure nimble and timely processes are in place to review applications for clinical trials, as well as submissions for authorizing COVID-19 treatments and vaccines. Plus particulièrement, nous reconnaissons la grande importance des vaccins en réponse depuis le début de la pandémie.
Since the start of the pandemic, Canada has collaborated with other departments and the working group on...
We seem to be having a problem with the English translation. The French is coming through very well on the English channel, but the English translation is very, very weak. I wonder if we could have a look.
This is the English interpreter. Can you hear the English? This is the English interpreter on the English channel. Can you hear? Yes, we do have the remarks. Yes, we have. Thank you. We can continue. Thank you very much.
Can you?
Of the French section, what would be your easiest for everyone?
The beginning of the French would be best, so it comes through loud and clear for all members.
From the beginning of the French section then, or?
Yes.
Yeah, okay.
Thank you, Doctor. I'll make allowances on your time for that.
No problem.
Please go ahead with the French.
Would it be easier if I just continued in English, or whatever works for the committee?
We have translation, barring sound issues and so forth. Maybe just whatever you were saying in French, just carry on with that to start with, and carry on from there.
Okay. Depuis le début de la...
Since the start of the pandemic, Health Canada has worked closely with other departments and the Vaccine Task Force to develop and implement Canada's COVID-19 vaccine strategy. Early on, we recognized the need to facilitate clinical trials of drugs for COVID-19, given that no treatments or vaccines were available for this new virus. In May 2020, Canada's Minister of Health approved an interim order to facilitate clinical trials for COVID-19 products. Among its benefits, the interim order reduces the administrative burden for sponsors without compromising the safety of participants, and this makes it easier to set up trials across Canada. In September of 2020, the Minister of Health introduced another interim order to expedite the review of treatments and vaccines for COVID-19 while maintaining a high level of scientific scrutiny.
To approve a new vaccine based on available evidence with more agile administrative and application requirements, apply terms and conditions to require the manufacturer to continue providing information on the safety, efficacy, and quality of the vaccines once marketed, and permits Public Health Agency of Canada to arrange for the importation of promising COVID-19 drugs into Canadian facilities prior to approval in Canada. The interim order also allows for rolling reviews, which lets a vaccine manufacturer submit their request for authorization before they have completed all the clinical trials. This means that they can submit required data as it becomes available. Additionally, we have a strong post-market safety surveillance system to monitor the safety of COVID-19 vaccines. Once a vaccine is on the market, Health Canada and the Public Health Agency of Canada monitor for any adverse events after immunization, in collaboration with the provinces and territories and the manufacturer. The interim order provides the authority to impose terms and conditions on any authorization at any time, such as conducting additional assessments of safety information. All of Health Canada's regulatory decisions are independent and based solely on science and evidence. Jusqu'à présent, 10 demandes ont été.
So far, 10 submissions have been received under the interim order, including 4 treatments and 6 vaccines. 2 vaccines and 1 treatment have been authorized, while the others remain under review. Another key step that we have taken to ensure timely and thorough approvals is hiring additional scientists and establishing dedicated review teams for COVID-19 vaccines in order to ensure consistency in reviews. These review teams, comprised of experienced regulatory and scientific experts, focus solely on COVID-19 work, and they've been working around the clock on these scientific reviews of submissions. Health Canada's reviewers are scientists and physicians with many years of experience reviewing vaccines, and they have expertise in different domains, including, but not limited to, clinical medicine, toxicology and pharmacology, biochemistry, virology, immunology, microbiology, and other scientific disciplines relevant to the development, testing, and manufacture and quality control of vaccines.
There with information that vaccines were going to be developed, our department worked closely with other international regulators and the World Health Organization to collaborate on the regulatory requirements for COVID-19 vaccines and to make the regulatory processes as efficient as possible. These partnerships allow us to share information, support scientific collaboration, and align regulatory approaches and requirements for vaccines while still making independent decisions for Canadians. Together, these measures have allowed Health Canada to authorize several clinical trials in Canada for COVID-19 vaccines, as well as the 2 vaccines, Pfizer-BioNTech and Moderna, which are already being administered to Canadians. Notre réponse à la pandémie est guidée.
Our response to the pandemic is being guided by the latest science and research. We also continue to monitor the emerging viral variants closely and work with manufacturers and international regulators to assess the impact of the new variants on vaccine efficacy and provide guidance to manufacturers.
And transparency, Health Canada has published detailed information about the authorized COVID-19 vaccines on the department's new COVID-19 vaccines and treatments portal. Health Canada and Public Health Agency of Canada also provide weekly updates on reported adverse events following immunization. Canadians can feel confident that the review process for vaccines is rigorous and that we have a strong monitoring system in place. Once again, thank you for this opportunity to speak with the committee today. I'd be happy to answer any follow-up questions regarding Health Canada's vaccine approvals process that you may have. Thank you.
Thank you, Doctor. We'll start our rounds of questions now with Ms. Rempel-Garner, please. 6 minutes. Go ahead.
Dr. Perzada, thank you so much for taking time to be here today and for your service in our community. You might not realize this, but you've actually had an impact on me and my role as the Vice Chair of the Health Committee since I was appointed last fall. Since the pandemic started, I've always been of the opinion that in order to reduce the larger societal impacts of lockdown, that we should be looking at ways to undertake more targeted isolation measures supported by rapid testing so that we can prevent the spread of COVID, but also reduce, the harm of domestic violence, suicide rates, mental health, surgeries being canceled, all the stuff I'm sure you're seeing. You wrote an article in the fall talking about the need to have rapid test deployment. And here we are, we're like 6 months later. We're on track to have, I think it's less than 10% vaccinated by the end of March. Do you think it's time that we need a federal strategy on rapid testing deployment?
Oh, definitely. This is an underused technology, and many, like Slovakia and other countries, have used it to lower the burden. And, baby steps have started in Ontario on rapid testing. But I think, we bought 20 million of these tests, but we need 10 to 20 million of these tests every week. If we can get everyone testing quickly, 2-3 times a week, we can really bring down the numbers and make things like opening schools a lot safer. So I think this should be definitely a priority for the government.
Well, I'm half Slovak and I met with their ambassador on it, and I know it's been going very well there. you know, I've heard everything from the federal government, from rapid testing isn't a panacea, it won't work, to it's not our responsibility. We bought the things for the provincial government, they're not deployed. I think Canadians are starting to get tired of the finger pointing across jurisdiction. How could given our jurisdictional boundaries, how could the federal government take a more active role or provide more value add in deploying a test like this, especially knowing that, you know, vaccinating everyone is probably another 6 months away at best, at very best?
So I would say licensed manufacturer here. There's a great company in Halifax, Sona Nanotech, that makes them. We can make them here. We could license it from Abbott as well. But you know, we need tens of millions of these tests every month. We need lots of them. Get them in the schools. Get them at the workplaces that keep having outbreaks. We know that they'll work with the variants as well. So that's a great strategy if we can get them out there. Approve more of them. There's some tests that are approved in Europe that aren't approved here yet. Just get them out there and get them to work.
Yeah, I mean, I listened to the chief public health officer on Friday, and she, you know, made a statement that it was unlikely that Canadians were all going to be vaccinated this year. But she also presented some projections on the spread of the variant. And on Friday, we had officials from PHAC here talking about what the modeling included and didn't. And I was really surprised that they weren't able to speak to assumptions around rapid testing and vaccination in future models. Do you think rapid testing, if we had a national strategy, it could help us prevent the spread of the variant?
I think it's something to be considered, but with the variant, it's way more contagious. So airborne spread, just look at the building outbreak in Mississauga. It did not happen people in close contact with each other. They were in vestibules, maybe in elevators. So anything needs to be done to stop the spread of that. So it's something that would really help, I think. But along with other things like fixing ventilation, getting people to wear improved masks as well. So those are all important things.
Oh, great. You know, if you want to table some recommendations that are further on that to this committee, we would love to have them. You know, I guess the other thing that I took away from some of your writings and your testimony here today, and frankly, as a policymaker who, like, I have people calling in my office and saying, when is this going to end? I think that the general theme of the last year and a half has been a lot of inertia within our bureaucracy and not a lot of direct input, either from people who are, you know, dealing with this on a daily basis through lived experience, or from frontline medical workers. If there were three things or more that the federal government could do today to have more input from folks like yourselves to overcome this inertia, what would that be?
So I think get us here more often. There's lots of people like me out there who have a lot of good observations. The medical community really wants to talk to you guys and get our viewpoints. The second thing right now is just tell the public to really look out for airborne spread of this virus. Where, you know, N95s are easy to find now. Lots of Canadian companies are making them. We've got a great list online if you can search for it. The third thing I would say is really listen to the science and try to get ahead of this. We know Europe has given us a great head start, and just follow what they're doing that works, and really think about single dose vaccination like what the UK is doing. I think they're going to be the first out of this first, I think.
Thank you. With the time I have remaining, to Dr. Bernstein, when you were on the vaccination task force, and I know you sit on there now, did you recommend that the government enter into the CanSino agreement?
Well, the CanSino collaboration between the NRC and CanSino actually started before the vaccine task force was formed. So when they came in front of us, it was partly an FYI, but partly for us to comment on the science behind.
And what was your comment?
Our comment was that there was two things. There was sort of good news and bad news. The good news was that at that point, CanSino was actually way out in front of any vaccine developer in terms of having a vaccine for human use for COVID-19.
And the bad?
So the bad news was the science into it. I can go as deep as you'd like into it, but because it was an adenovector, and we all have antibodies to the adeno5 vector that was used in the CanSino vaccine, that there was a worry that there would be antibodies that we would naturally have already been making to the vector itself, to the vaccine itself. And so there was a question of how effective that vaccine would be. And so we provided that information back to them. When we saw the later data later on in the summer, we then recommended that the collaboration end.
Thank you, Ms. Rumpel-Garner.
Thank you.
We go now to Ms. Sidhu. Ms. Sidhu, please go ahead, 6 minutes.
Thank you, Mr. Chair, and thank you all the doctors and for your insight. Dr. Sharma, very briefly, can you take us through the process that goes into giving new vaccine full authorization in Canada so they are safe for all Canadians, very shortly?
Certainly. Thank you for the question. So, Mr. Chair, there's a review process that involves review teams with a lot of experience. Each review team has about 7 to 10 people on it in a variety of different scientific domains. They look at the preclinical or the lab and animal data. They look at the clinical trial information, and they look very detailed, have detailed examination of the manufacturing data in separate groups and in areas of expertise. And then all of that comes back together to see if that vaccine will meet the appropriate standards for safety, efficacy, and quality, and as well as if the benefits of that vaccine outweigh the potential risks. In addition to that, there's a group that looks at what we call the risk management plan. So that's the plan for post-market monitoring of the vaccine. We have teams in Health Canada that also look at all of the assessments of the facilities that the vaccines will be manufactured in to make sure that they adhere to good manufacturing practices and standards. So once all of that comes together, there are look at the labeling, the post-market commitments, the terms and conditions on the vaccine, and the plans for monitoring, and all of that goes into the authorization. All of that in the Canadian product monograph, a summary of our review, all the information that we base the review on, then goes up on the website so that it is accessible for all Canadians. Thank you.
Thank you. Dr. Sharma, federal government provided almost 23 million rapid tests to support provincial and territory partners. There are millions currently collecting dust at provincial facilities. What do you think should be improved to make sure these procured tests are used by our provinces and territories?
Well, certainly from the regulatory standpoint, we've done expedited reviews to make sure that whether it's a point of care test, an immunology test, or lab-based test, that those are reviewed and authorized if they meet the Health Canada standards. The Government of Canada, as you noted, has gone through a lot of procurement of rapid tests and have deployed those on the basis of need in the provinces and territories. So now in terms of the deployment, that is really at the provincial and territorial level to see where those rapid tests and indeed other rapid tests that they may have procured fit into their overall testing and contact tracing programs, but certainly it's an essential part of the track and trace for cases of COVID-19 and helps, of course, a lot in terms of the response to the pandemic.
Thank you. A few days ago, Dr. Tam said we can be very optimistic about the performance of the vaccines so far based on that data collected. And there's a growing evidence that one dose provides a fairly high level of protection. Can you tell us about how the first phase of vaccination are providing effectiveness? Very briefly, please.
So certainly the two vaccines that are authorized so far in Canada are the Pfizer-BioNTech and Moderna vaccines. Those are both two-dose vaccines. And the reason that they're two-dose vaccines is really based on all of the developmental tests that have gone into the development of those vaccines. So from animal studies and through lab studies and through the clinical trials. And the concern with only using one dose is that potentially that immunity could wane after a period of time. And that's why one of the terms and conditions on both of those vaccine manufacturers are to continue to monitor the people in the clinical trial for up to 2 years. Now, the research that was done both in British Columbia and in Quebec is very important. We absolutely need research in the real world application of the vaccination programs. It was reassuring in two points. One is that we didn't have clinical trial information for people in the older age groups that were in long-term care facilities, so that were potentially more frail. And the concern in those groups is that potentially you could see less efficacy. So one reassuring thing from this data has shown that we are seeing a good response in those groups. Now, the way that the vaccine effectiveness of the one dose was calculated was using something called crude vaccine effectiveness. So it's not comparing people who got the vaccine, and who didn't get the vaccine. It's really looking at timeframes within the groups that got the vaccine. So it is useful, but it is limited. So right now it's good information. I think the authors themselves noted that before we would recommend that we would only have one dose, that more research needs to be done, but it is reassuring that if there is a delay for that second dose, it likely does not have a significant effect. So the companies would have to come in if they wanted to change their vaccine to a one-dose vaccine with evidence to Health Canada. We would review that, and if it was suitable, we would change the labels.
Thank you. Mr. Chair, do I have more time?
You have 30 seconds.
Quickly, Dr. Bernstein, there are few groups that were not part of vaccine trials, such as teens or pregnant women. Can you provide insight on any research that has been done to make sure these vulnerable groups are protected?
Yeah, thank you for that excellent question, Mr. Chair, if I could respond. Typically in vaccine trials, teens and pregnant women are not included in the first instance because they represent a sort of a high-risk group, and so there's a concern that they not be exposed to a vaccine until it's been tested to be safe and effective by the regulator. But as we speak, indeed, there are now trials going on with younger age volunteers in those trials to see indeed whether the vaccines are safe as well as being effective in younger children. I think the same will be true for pregnant women shortly. The WHO and both the US FDA have issued sort of guidelines which are somewhat contradictory around that. On balance, I think the view is that it's probably safe and effective for pregnant women to take the vaccine, especially because there is good evidence that being infected with the virus, if you're a pregnant woman, makes you particularly susceptible to a serious disease outcome. But again, the trial has not yet been done.
Thank you, Ms. Sadu. We go now to, nous allons maintenant à Monsieur Thériault.
Moving on to Mr. Thériault. You have 6 minutes, please. Thank you, Mr. Chairman. Dr. Sharma, some people believe that since AstraZeneca cannot deliver its vaccines to Canada before April, and approvals are lagging, it's taking a long time, even though the vaccine is being administered elsewhere. Why is this happening? For scientific or political reasons? Why have we not approved AstraZeneca yet? And what's missing?
The AstraZeneca submission is ongoing. We have gone through the bulk of the scientific information. This submission was a bit more complicated than the ones that we've seen with Pfizer and biotech because of the way that the data was collected. We also note that different regulators are taking different approaches to how the AstraZeneca vaccine should be used. So currently we're still going back and forth with the company with respect to some data. We've just had some conversations with them today. It is in the final stages, but that end process around the product monograph, the labeling, the indications, the risk management plan, and potential terms and conditions on the vaccine are still under discussion. We know that the European Medicines Agency has authorized the vaccine. The other largest regulatory authority, the US FDA, is still waiting.
So this was the only, or rather, if this was the only vaccine candidate available, we'd still be waiting. You still would not have approved it at this point. That's what I take from your answer. Some people believe that the RNA messenger technology is more effective against the variants. What would you say to that?
We've seen for both Pfizer and Moderna have shown that their vaccines are quite effective against the 117 variant, so the UK variant. Both of those mRNA vaccines in laboratory studies have shown some decreased activity against the 501 variant, which is the South African variant. But because it was starting with such a high level of efficacy, it was still at levels that were protective. So both those mRNA vaccines at this point in time are deemed to still be protective against the variants that we know of so far.
Non, la question, c'est pas de savoir.
Well, the question was not whether those two vaccines were good now against the variants. What I'm talking about, the RNA messenger technology. Will that technology be easy to tweak so that it's effective against future variants? What do you think about that?
Vaccine platforms. The thought is that the mRNA technology would be the easiest, would be the quickest to redesign in terms of changing the vaccine to respond to variants. Although the vector vaccines, the viral vector vaccines, also can be changed quite rapidly. But you're right. The mRNA vaccines would likely be the ones that would be the quickest to change.
Dr. Bernstein, you said that mixing vaccines, that is, giving a first RNA messenger vaccine and a second vector virus vaccine, might be potentially a good idea. What would the advantages and disadvantages be, and the risks be, of mixing or combining vaccines? And do we have evidence or data when it comes to that?
Chair, if I could respond. Yeah, I've been quoted in an interview in the newspapers that I think mixing and matching has several advantages. One is for the viral vector vaccines, like the AstraZeneca Oxford vaccine. The second time you come in with the second shot, the host will have already perhaps mounted an immune response against the vector itself, and so you'll have a diminished effectiveness of the vector or the vaccine second time around. Whereas if you only give it once and then come in, for example, with the RNA vaccine, you're combining the best of both worlds. And so that's one of the reasons. The other reason is there's evidence that the RNA vaccines are particularly good at mounting one arm of our immune system, making antibodies, whereas the viral vector vaccines are particularly good at mounting another, activating another arm of our immune system, which is the so-called cellular arm of our immune system. And so by combining the two, you get, again, the best of both worlds. I think the third reason, of course, is that in terms of vaccine availability, if we find that we have a lot of one and not the other, that there's another argument for doing both. I think the bottom line is we won't know until we do a trial to really measure the effectiveness of that mix and match strategy. And so that trial has begun in the UK, and I think here in Canada, my recommendation is that we should also consider doing such a trial as well, perhaps in partnership with the British. The last point I would make on that, well, my little headphone here is coming off.
Seraient très chaudes à cette idée-là.
I don't know how enthusiastic we'd be about, or rather, whether our government would want the responsibility to see whether combining the two vaccines is indeed effective. We'd need a lot of support from the scientific community.
But the endpoints for these trials would not be whether they're protective, which would take a long time and a lot of people in the trials. The endpoint could simply be how well do the mix and match strategy elicit a very robust immune response relative to not using a mix and match strategy, just as that is going in with 2 doses of the RNA vaccines or 2 doses of the viral vector vaccines. So those are quick trials that could be done over a period of about a month or so to assess this. And so I think there are some.
Mais à qui attribuer l'effet adverse?
Well, there is the matter of side effects as well.
See, Monsieur Thériault. Thank you. We will go now to Mr. Davies. Mr. Davies, go ahead. 6 minutes.
Thank you. First of all, Dr. Bernstein, thank you for your service on the vaccine task force.
Thank you.
Dr. Bernstein, I know that the analogous organization or committee at the World Health Organization offers open access to its meetings. And in the US, the vaccines and related biological products advisory committee publishes its agenda, it publishes its conclusions, and the entire meeting that they conduct are webcast on YouTube for anyone to see. Is there anything different about the manner in which Canada's Vaccine Task Force conducts its meetings that would prevent that kind of transparency?
Thank you for the question, Mr. Davies. Mr. Chair, I'd have to look at exactly what those other two committees do to give you a complete answer. I would say that when the Canadian Vaccine Task Force got started, our concern, we were just swamped with the need to identify as quickly as possible those vaccine candidates that would yield the very best vaccines for Canadians. And indeed, here we are now, 7 months later. I think all of us feel very proud of the fact that the 6 candidates that we identified, that the international ones, are exactly the 6 that everyone in the world now wants. And so we did our due diligence, I think, absolutely correctly. So that was our number one priority. I think the second priority was, as you said, the transparency, or making things more open. And I certainly think that there would be room for us to do that. Part of the issue, of course, was we were providing advice to ministers, which, as you know, is confidential in the parliamentary system. And secondly, there are some industry issues. So every company that came in front of us required, both Canadian and international, required that we all sign confidentiality agreements with them. And so indeed, there were confidential issues from the company's point of view that we could not release. So there are some issues there.
Okay. Now, I'm going to ask you a question I asked a previous panel member. Last Thursday, the co-chair of the Federal Vaccine Task Force, Mark Lieberman, told the industry committee that domestically producing and supplying a COVID-19 vaccine was never possible before the end of 2021. Those were his exact words. Now, we all know that the Prime Minister last August, on 31st, he issued a press release saying that the National Research Council would be producing 250,000 doses per month in November and millions by the end of 2020. I'm just trying to get a straight answer from someone. Did Canada have the capacity to produce vaccines in 2020, or didn't we?
Thank you for the question. I'm a fundamental scientist, not a vaccine manufacturer, so you'll understand when I say that it's really outside my own area of expertise. When we discussed that issue on the Vaccine Task Force, I think the issues that came up pretty quickly were how complicated it is to make vaccines. These are not like the N95 masks that we just heard about, for example. These are biologics that are being injected into healthy people. So it's very sophisticated science. It's very sophisticated public health issues. And so the production and the manufacture of all these vaccines is very complicated. Mm-hmm. Indeed, if you look at the holdup in the Pfizer, which is a very experienced vaccine manufacturer, in scaling up their manufacturing, I think you get a sense of how complicated it is.
Right. Well,
to actually
with
make
respect,
vaccines.
Dr. Bernstein, I have limited time. The question's about capacity, though, not about complexity. Now, on November 26th, you noted in an article in National Post that the federal government should consider working with AstraZeneca to produce the vaccine at the NRC's Royal Mount facility in Montreal. You were quoted as saying 250,000 doses a month would make a big difference for us. You know, that's probably the number of frontline healthcare workers. Why did that not happen in Canada?
Well, you have to ask the NRC about that. But well, first of all, thank you for the question. I think the issue is at that point, of course, the NRC had ended their partnership with CanSino, which is a viral vector vaccine along the same lines as the AstraZeneca vaccine. I think they were in discussions with AstraZeneca. I think you heard that from the president of the NRC. And then at that point, we're also simultaneously in discussion with Novavax, which ultimately has led to sort of a successful completion. So I think they were looking around for a partner that would come in and work with them on that. But what I meant was by saying that is, if we had domestic capacity, of course, we could scale up and rapidly produce vaccines here.
Okay. Can I switch to something else? Can you confirm if the Vaccine Task Force recommended ordering vaccines based on weekly, monthly, or quarterly delivery targets?
We did not. Our primary concern was the quality of the science, whether the company and its partners were capable of doing the trials, and whether they were capable of scaling up. The procurement issues were all handled by the Department of Procurement, Minister Anand's group.
Okay. Do I have time, Mr. Chair?
20 seconds.
I'll try to get this out. A senior government official recently told the press that the federal government's plans to commence a mass vaccination campaign in April were thrown off when Health Canada approved the Pfizer and Moderna vaccines earlier than expected. According to that official, Canada's contracts with the two companies, which have not been made public, focused on large-scale shipments after April 1 because the federal government believed no large supplies would be available before then. Can you confirm if the Vaccine Task Force advised the government to structure supply agreements based on that assumption?
Thank you for the question. We did not get into any of the details of the procurement arrangements. We simply recommended to ministers which vaccines should be purchased and which ones should go to the NRC for IRAP, as I indicated earlier. I think all of us, and not just in Canada, but in the world, I would just say, we're surprised at how quickly we were able to develop vaccines in less than a year. It is a remarkable result. But I don't know what was in those procurement agreements.
Thank you.
Thank you, Mr. Davies. Committee, that wraps up round one. We don't have very much time left, but I'm going to propose we might be able to sneak in a 1 minute round with everybody. And in that case, I would suggest you keep your questions to 30 seconds and allow 30 seconds to respond. So on that understanding, I would suggest, I think for the Conservatives, I think we have Mr. D'Entremont is next. Please go ahead, sir.
Thank you. I mean, we had some pretty disappointing testimony last Friday about data and exactly how many Canadians need to be vaccinated before we have herd immunity. So maybe this is a question to Dr. Sharma. Do you have any modeling that would actually tell Canadians how many people need to be vaccinated to get out of this pandemic?
So in terms of herd immunity, I mean, in general, herd immunity is the number of people that need to have immunity to protect people that are within the herd that do not have immunity. So whether you get it through having had the disease or being vaccinated, it's that protective sort of effect. Now, herd immunity for a virus can be anywhere from 50% to 90% of people that need to be vaccinated. And, certainly with respect to COVID-19 and the virus, the SARS-CoV-2 virus, when we were first looking at it, I think we were looking at estimates of around 60 to 70% that we would require being vaccinated. Now with the emergence of variants, and because they are more transmissible, I think a lot of people are adjusting those numbers up, towards more like 85% or even potentially 90% coverage to achieve herd immunity. But certainly that's something it's a moving target because the virus and its transmissibility and how contagious it is changing as we know.
Thank you, Mr. D'Entremont and Dr. Sharma. We go now to Dr. Pawlowski, please. 1 minute, please.
Okay, there was some very interesting news coming out of Israel from the Israeli Health Ministry and Pfizer, which seems to have very thorough reporting of data. They're saying that the Pfizer vaccine reduces asymptomatic cases by 90%. Now, if I get that right, that's really significant, and they seem to have the same interpretation. This means a lot because previously we thought you could get the vaccine, but maybe you still get an asymptomatic infection and you can transmit it on. So this would seem to me, if true, and I don't know whether you think the data is adequate enough, this would seem to have immense implications for a lot of different policy areas, from whether or not people who worked in chronic care homes could continue to do so without being vaccinated, to opening our borders to people who've been vaccinated. How good do you think that data is, and should we make policy decisions based on
it? Please go ahead with the answer.
I wasn't sure who the question was addressed to.
Either Dr. either of you, Dr. Sharma or Bernstein, whoever wants it. Go ahead.
Dr. Sharma.
Sure, I'll start. So you're absolutely right. There's research coming out of Israel that has been interpreted as potentially being information that would talk to transmissibility. Now, the research in Israel was really around viral shedding. So what they found is that there was a decrease in viral load in those people, and so they would shed less virus, and so then the conclusion was that potentially they would be less transmissible. Now, that I think that is, it's an interesting hypothesis. We still don't know exactly how that correlates. So the amount that the virus that you shed, or what type of virus it is, or what phase, and how that directly translates to transmissibility. So whether it's for the Pfizer-BioNTech vaccine, whether it's for Moderna that has some data around potential decreasing of asymptomatic spread, as well as AstraZeneca that shows in some studies that potentially it's about a 66% decrease in asymptomatic transmission. I think we'll have some data on the vaccines, but for all of them, it's not yet conclusive. Really, the studies have been designed to look at decreasing and preventing serious illness, moderate illness, and death. And we know that for all of the vaccines that we have under review and have authorized, that they all have very good outcomes there. But again, the transmission and the effect on the transmission is still an ongoing area of research.
Thank you, Dr. Pawlowski. We go now to Monsieur Thériault. C'est à vous. Une minute.
Merci, Monsieur Dr. Bernstein.
Thank you, Dr. Bernstein. To get out of this pandemic, everyone in the world needs to be vaccinated. 92% of vaccines are administered in rich countries now, and you're saying that these wealthy countries have said that 5 to 10% of the vaccines they have reserved should go to developing countries, that is, countries which don't have the money to sign bilateral agreements with vaccine manufacturers. What do you think of the fact that Canada is going to take from those vaccines from the COVAX fund?
Question, Mr. Chair. I think the answer here is there are two. It's complicated with COVAX. There are two pots of money or two bank accounts within COVAX. One is a donation that countries make, including Canada, to buy vaccines for the developing world. And the other is for vaccines that they're entitled to withdraw for themselves. I think the important point is...
Pas de traduction, excusez-moi.
There's no translation.
Sorry,
si vous voulez recommencer.
Could you please start your answer again? Thank you.
Okay.
Do we have translation now, Monsieur Thériault?
Is the translation... Should I start talking now?
Just hold up here. We'll make sure we have translation. So I wonder if the translation could, or Mr. Thériault, if you give us a thumbs up if you're getting translation. Okay, we're good.
Okay.
Yes, doctor, please resume, or please start your question over. I don't think Mr. Thériault got any part of your answer.
Sure. I think it is important that Canada be a major contributor to both COVAX and other mechanisms to vaccines for the developing world. Indeed, I think we are, until the US came in, the largest contributor per capita to the COVAX facility. But it's in our interest to make sure that everyone in the world is vaccinated as quickly as possible. And that Dr. Sharma alluded to the variants that have appeared, inevitably, actually. And those variants will appear anywhere, and the number of variants that appear will be directly proportional to the size of the virus pool that's in the world. And so it's in our interest here in Canada to shrink that virus pool as quickly as possible. And the best way to do that is to vaccinate the whole world as quickly as possible. So I think Canada has a moral as well as a practical reason for donating vaccines to the rest of the world, either through COVAX or through other mechanisms, directly to Gavi, the Vaccine Alliance, or through the WHO. So I think that is very important. Canada has, at least on paper, purchased more vaccines per capita than any other country. And so if all those vaccines are eventually approved by Health Canada, we will have the opportunity to donate a lot of doses to COVAX or to the developing world directly. So I think the important point is that we actually step up and donate those vaccines to the developing world. Thank you.
Merci, Monsieur Thériault. I note, Dr. Pawlowski, your mic, if you could mute it. Mr. Davies, please go ahead, 1 minute.
Dr.
We'll give you
Bernstein.
a little bit more because everyone else took a little bit more. So
Thank you, Mr. Chair. Dr. Bernstein, just following up on that, there's a question of timing, though, as well, isn't there? Do you think that rich countries should be vaccinating their young and healthy before frontline healthcare workers and vulnerable people are vaccinated in developing countries?
Well, right now, young people are not. The vaccines have not been approved yet for young people here in Canada. Again, I think there is a good argument, both a moral argument and a practical one, that the G7 countries, including Canada, donate vaccines to the developing world initially for frontline healthcare workers, as you've suggested, Mr. Davies.
Thank you. Dr. Sharma, at a technical briefing on February 9th, you noted that Health Canada's review of the AstraZeneca vaccine was in the final stages and was just awaiting some final, quote, back and forth with the company to finalize the rules for how the vaccine is to be used and on whom. Considering that the vaccine is already approved in other countries, can you confirm when you expect a decision will be made with respect to the AstraZeneca vaccine in Canada?
So thank you, Mr. Chair. So as I noted before, that review is ongoing. Certainly, we have completed the review of the science, and now it is the final stages. The length of time that takes is really dependent on a number of factors. So the questions that we pose to the company, how long that they take potentially to get back to the evaluators with those responses. And so that dialogue with the company in terms of the finalization of the review is ongoing. And I just wanted to highlight again that it's complicated. We know that we've got different regulators that are looking at the same data for AstraZeneca and are making different decisions based on the science. That's why this is taking a little bit longer than the ones that we have done before.
Thank you, Mr. Davies. And thank you all to the committee, and thank you to the witnesses for your sharing your time with us today and for your excellent testimony. And with that, we are now adjourned. Thank you all.